Hey guys, and welcome to Hymnology. I'm Shari James. For those of you who don't know, I help men avoid ED medications, get off of them, or in some cases get them to work with my holistic approach to healing erectile dysfunction. Today, I have my first live in studio guest, Gerry Letendre.
Thank you, Shari. Thank you for having me.
Gerry is a pharmacist who's been practicing specifically in men's health for over the last 20 years, specializing with men that have had prostate cancer resulting in erectile dysfunction. I should also introduce what does she do? What is she doing? She's warming up the audience. So yeah, she's the warm up. I would like to start with wisdom bomb number 1, which is prostate cancer doesn't have to be the end of sex.
Well, Shari, what I see in my practice are men that have been diagnosed with prostate cancer, and you can imagine that their whole world is turned upside down at the time, and they're concerned about surviving prostate cancer, which is highly survivable, and the last thing they have on their mind is sex. So the first year after either surgery or treatment, they are exhibiting the typical common incontinence issues. They're not really thinking about having sex. But I do find after 12 or 18 months, they want to get back in the game, as I call it, but basically reapproach sexual activity. So at that point there, inevitably, they have been given the typical Viagras and Cialises. But unfortunately, 50% of them are just not effective for that, or they have side effects, and that's another reason why they discontinue it. So typically, the next approach would be, penile injections. Of course, men are, and most people are needle phobic, but specifically men in that sensitive area. So, so they reluctantly approach it, but again, they really desire to have sex again. So. That urologist will typically prescribe something like that. I work with several large groups here in Sarasota. They send them specifically to me because I spend 15 or 20 minutes training them. They have a lot of questions. The doctor typically will give them 5 or 6 minutes. They'll give them a quick instruction on how to use the injection, but are not typically available for follow-up questioning. And that's another area that I provide for them. Yeah. They can more easily reach me than they can the doctor. And I have trained well over 200 men in the last 17 years. So I have a lot of user feedback on some of the issues that they may have, and certainly questions. And we go from there. So it's really more of an interactive question answer. When they leave my training, they feel very, very comfortable on how to use it. And just as importantly, if for some reason they fail on that particular formula, we have 20 or 30 different formulas. So we can customize it. I'll debrief them. I'll be sure they're using the proper technique. I'll ask for the response that they got. And then from there, we'll make a recommendation to the doctor. And I have a 99.9% success rate for the referral. And because the doctors will defer to me with my experience and my success in the past. So it's been very rewarding personally and professionally. And these poor men, they really understand, and certainly I understand how important sex is for men and for women, of course, as well. So
here's the question: what is the number one, I want to say, surprising thing or challenge that men have with injections?
Well, one of the 3 things that I tell them up front that we don't know. Number 1 is we don't know what their dose is ultimately going to be because everybody is different. Circulatory health is different from men to men. If they have high blood pressure, cholesterol, diabetes, these are all medical factors that interfere with that. The other is we don't know how quick the onset of action is going to be. So this is something that they're going to find out through trial and error. And we don't know about the duration as well. So these are the 3 unknowns. And that's why we start very low as far as dosing is concerned. We use 20 units on an insulin syringe. They will get a response because the drug is right into the shaft of the penis. I suggest they look at their watch, see how quickly it starts working. and then wait at least 24 hours before they increase by another 10 units or 0.1 cc. So the whole focus on the go low, go slow is so they don't jump ahead and run into some issues that we'll talk about a little bit later. So once they have that dose, then they can preload their syringe to whatever their dose is ultimately. And then there are starter ED injection formulas. And then we increase by increasing the number of drugs in the injection.
So it's essentially subjective and experimental?
But trial and error until we come up with the right dose. And then oftentimes I will tell them if they get up around 70 or 80 or 0.7, 0.8 cc's, and they don't get an erection for penetration, to call me. I'll debrief them to be sure they're using the proper technique. And at that point, they make a recommendation for another formula if necessary, if that's what they want me to do.
Okay. I love that you're so involved in this process.
Well, it's a very sensitive area. And as I say, the doctors, nurses, and the doctors themselves are not available to get the proper feedback from the patient as to what's working and what's not. So that's where I can.
All right. I think we're ready for Wisdom Bomb number 2. Revealing the typical path of post-prostate cancer and sexual performance. So you're going to reveal what the typical path is.
Well, oftentimes, again, after 12 or 16 months, when these individuals want to get back into the game, as I call it, they will approach their urologist for solutions to that. And the first approach, as I had mentioned previously, would be the Viagra's or Cialis and those types of things. And I would also make mention that these ED injections are not to be mixed with those oral agents. There's one exception, which is sometimes individuals, men are on a low-dose Cialis for BPH, and in that particular case, it's okay to combine the two.
Do you want to say what BPH is for people who don't know? Well, it's
basically an inflamed prostate that causes a lot of issues with frequent urination, even if there's no urine involved. So it's an inconvenience, but in that particular case, the Cialis at low dose is appropriate, and it can be used with these injections. But typically, as I mentioned, the physician, the urologist usually will prescribe these oral agents, but as I mentioned, only half of the men respond either with an erection, or oftentimes it's a side effect profile that keeps them from, it causes nasal congestion, and sometimes there's some aura around lights, so it's uncomfortable, and they're willing to put up with those side effects. So at that point there, the next step would be the ED injections.
Well, if I may, do you find that they cap out at 100 milligrams on these medications and then graduate to injections? Yeah,
they'll maximize the dose, whatever the usual dose is. Usually for Cialis, it would be 20 milligrams. For sildenafil or Viagra, 100 milligrams is the top dose. And if they don't get the quality of erection they're looking for penetration, then that's when the doctor would go to the ED injections. And there's a series of, let's say, beginner injection formulas, and then proceeds up to 2 drugs and then 3 drugs. So you have a single drug entity, and then you have something called a bimix, and then something called a trimix. So that's the usual progression to that. And once again, it's all dependent on the individual's circulation quality, and they find that out through, again, trial and error. So
okay. All right. And I think we're ready for Wisdom Bomb number 3. The benefits and dangers of ED injections.
Well, the usual process, as we all know, is we have an arousal thought. It sends signaling down to the penis, causing engorgement and erection, and then ejaculation, and then it reverses fairly quickly. With the oral agents, essentially the same connection is necessary. You need to have an arousal thought. Signaling gets down there. It's kind of supercharged, if you will. You either get an erection or you don't. You have an ejaculation, and then the process reverses. This is totally independent of that connection. When we inject the drug right in the penile shaft, it causes vasodilation. So it's not necessary to have an arousal thought. So that's the good thing, if you will, especially if there's been a disconnect because of treatment for cancer and or surgery. So, and the other, but another positive thing is after an ejaculation with an injection, it stays erect. So you can continue with sex a little bit longer.
If
They're
ejaculating depending on which treatment they got.
Correct.
Yeah.
And not all men ejaculate, which was an eye-opener for me years ago, and I found that that is the case. Now, the danger, of course, is if the erection lasts too long. And so
yes,
how
long is too long?
Well, the drug companies say 4 hours. I'm more conservative. I say 2 hours. If you're still fully erected, hour 2. Then I do have a rescue technique that involves increasing activity so that your circulation increases and the drug is flushed out of the shaft quicker. Then there's a pseudoephedrine also involved in this technique, which essentially opens up the shaft, as I call it, and allows the drug to be again flushed out. And I also remind them that even with that rescue technique, there's still going to be engorgement, but it won't be erect. So if it's still erect at hour 2 with the rescue technique, then they definitely need to get to the ER. So a priapism can cause some severe damage, resulting in.
Do you want to say what that is?
Well, scar tissue typically is one of the results, and scar tissue doesn't have the elasticity for engorgement for an erection. So it is a severe, serious medical condition, and it's not to be fooled around with. You really need to have some medical assistance at that point.
So for guys that are post-prostate cancer, or even not post-prostate cancer, and have just tapped out on 100 milligrams of not Cialis, but Viagra, or Cialis goes to 100?
20 milligrams.
20, yeah. So when you've capped out on the PDE5 inhibitor that you're on, I mean, injections are certainly an option. Obviously, there's my work, which gets to the bottom of the 13 root causations. So I definitely recommend contacting me for that assessment so that you're not shooting in the dark, so to speak. What are your thoughts on a holistic approach to finding out the causations and also healing erectile dysfunction?
I think that has a lot of merit because a lot of men are apprehensive about using the medical approach, especially as far as injections are concerned, and as I had mentioned earlier, in that particular sensitive area. So they are looking for solutions, and it's not always the oral agents, the Viagras, the Cialises, and it's not always ED injections. I think your approach is more comprehensive. You look at root cause, and I think that's the better long-term approach as well.
Thank you. I could not agree more. All right. Well, thank you for being on the show today, Gerry. That was a lot of really great information about injections in particular.
Well, thank you for having me, Shari. That was a lot of fun.
Okay.
Informative.
Hey, you. Hey, guy. Who's learning about sexual health? Mixed in with some Tantra, mixed in with some 5 elements of Chinese medicine and some Western medicine. I want to let you know something. I would love it if you would hit my subscribe button and the notification bell. That way, you're going to know when new content is posted every Friday.